the gap between the funds needed to decisively end malaria and the funds actually deployed was widening even before the COVID-19 pandemic. But health experts are now concerned that the pandemic may actually have slowed down efforts in dealing with the disease. It killed over 400,000 people in 2019 alone. Let's start with the money side of the problem, shall we? According to the World Health Organization, the funding gap doubled between 2017 and 2019 to over $2.5 billion. In 2019, at least $5.6 billion was needed to just stay on track with efforts to eliminate malaria, but only $3 billion was actually invested. Now, of that $3 billion, 70% of it came from international sources outside Africa. 1.1 billion of that actually came from the United States. Now, there is a significant concentration risk here, since in the decade in between 2007 and 2018, 25% of all R&D funding came from just one source, the Bill and Melinda Gates Foundation, with the US through the National Institutes of Health investing nearly $2 billion in R&D. Even though the bulk of the global malaria caseload is in sub-Saharan Africa. Between them, Nigeria, the Democratic Republic of Congo, Uganda, Mozambique and Niger, they accounted for 51% of the global caseload in 2019. According to the WHO estimates, disruptions due to the COVID-19 pandemic may have resulted in an additional 10,000 to 100,000 deaths attributable to malaria in 2020. Now, to put that into context, the upper end of that estimate is about half of all deaths in Africa caused to date by COVID. Now, there is an additional problem to consider here when we're dealing with malaria: emerging drug resistance. Just last week, Novartis announced the results of phase 2 trials of a new drug to treat malaria. The good news is it demonstrated the same efficacy as ACT combination therapies that we're using now in that round of tests, even in children under 12. Some hours ago, I spoke to Dr. Nekoye Otsula. She's a Global Medical Affairs Director on malaria at Novartis. I started by exploring why it was absolutely important to have another mainline drug ready to deal with malaria, even when the current ones are about 98% effective.
What is a bigger concern for us today is the fact that we are seeing early signs of mutations to the malaria parasite, and these mutations code for resistance to artemisinin. And if we lose the artemisinin background, we're going to lose the other drug that it is combined with. So we do not want to wait until we're in complete failure, like we were in the 90s, and we have no option, before we start looking to see what can we use to, what drugs, what other options would be available on that day when the drugs are no longer working. So we are being proactive.
Indeed.
In order to have treatment options.
Do we know what's driving this resistance? Is this just natural adaptation, for lack of a better word, of the malaria parasite to the sort of things that it's having to deal with in its common environment, or are there other factors that are driving this adaptation?
Resistance is a naturally occurring phenomenon. So when you have a new drug, then the parasites will always try to outsmart that new drug that you have. So eventually, any anti-malarial or even antibiotic to step out further would eventually fail. However, there are things that we do that drive resistance. For example, people who have malaria and are prescribed an anti-malarial and then don't complete the treatment. They feel better in 1 or 2 days and don't complete the dose. What they're doing in their body is selecting for those parasites which are resistant to the treatment or partially resistant to the treatment that they're receiving, and they can then transmit these parasites to others.
And also there's this habit that we tend to have, at least in this side of the world, where, we'll self-medicate. We'll walk over to a pharmacist and say, well, I think I have these symptoms, I might have malaria, give me an anti-malarial, even though it might not necessarily be the case that we actually do have malaria.
And where this becomes dangerous is places where we have heavy malaria burden, like in the lakeside in Kenya, for example. We have people walking around with a sort of clinical immunity to the parasite. So they have low levels of parasites in their body, but they're not getting sick from them. So these individuals maybe have a headache for another reason, and then they go to the chemist and they get an anti-malarial, and then they don't complete it. So they would also be selecting for resistant parasites.
So the data that we've seen from these phase 2B trials, this looks fairly promising. Sample of 524 persons, and the efficacy of this particular drug is essentially comparable to what we're seeing with ACT combination therapies. Give us a summary of how this played out.
So the study was done in two parts. We had a part A, where there were adults and adolescents enrolled, and there were about 350 of those. And the drug was found to be safe and work well. Then we had a part B, which was the first time we were taking the drug to children less than 12 years, who would be our target age group. This is the age group where we have the highest burden of malaria. And the drug was found, considering all factors, to be comparable to artemisinin, to an ACT. So that's really exciting. The other thing that I need to underline here is that the drug was well tolerated. So it has a good safety profile. And the third thing is that compared to some of the ACTs, which are given twice daily, this drug is given once a day. So that's a great improvement.
Is, is, is malaria not getting the funding it deserves or the funding it needs simply because, well, it tends to be a tropical disease? 95% of those cases tend to be essentially in the tropics, in Nigeria, in Uganda, in the DRC.
In terms of funding, there you get more visibility when a disease obviously affects a higher number of people or a broader geographical region. And the truth is, malaria is now mostly a disease of the tropics. This wasn't always so. As late as the First World War, there was malaria in the southern parts of Europe. But over and above foreign funding, we do need to ask ourselves, what are we doing locally as governments in endemic countries? What can we do as communities in endemic countries? Because the malaria funding is not, funding from funding partners is not the sole solution. There's a lot we can do ourselves to own our history in malaria or our future in malaria.